country. So I'm thrilled to introduce our next session, where we will dive deeper into the role of MMRCs and how they actively work toward maternal mortality prevention, and how it will work in Indian country. So our following speakers are distinguished experts in the field and have actively advocated for maternal health in Indigenous communities. With extensive knowledge and experience, they are well equipped to shed light on the transformative impact of MMRCs and our efforts to promote maternal well-being, and I'll spotlight them here soon. And Dr. Jill Jim, who is the Director of Public Health Infrastructure and Accreditation Programs Director here at NIHB, will be moderating today's discussion and with our three panelists. And I'll start off in naming our panelists. So Cindy Gamble, who is a citizen of the Central Council of Tlingit and Haida Indians of Alaska and of the Man's Foot Clan. She has worked to support the health of women, birthing people, children, and families as a childbirth educator, school family life educator, DV/IPV prevention advocate, and tribal health director. Currently, Cindy works as a tribal community health consultant with American Indian Health Commission, also known as AIHAC, as lead for the maternal infant health and WIC and nutrition projects. She represents the AIHAC on a variety of state agency committees and work groups, including the Washington State Maternal Mortality Review Panel. Cindy is currently the vice president of the Tatawat Birth Justice Board and the past president of Nutrition First. She's also volunteered with the Canoe Journey Herbalist, and Cindy believes that the health and strength of Native families and communities begins with the healthy mothers and babies, and integrating the wisdom and ways of our elders and ancestors into our daily lives. And Cindy and husband Jerry have 3 adult children and 5 grandchildren. So I'm very excited to have you, Cindy. And next we have Dr. Brian Thompson, who is a clinical assistant professor at Upstate Medical University in Syracuse, New York. And Dr. Thompson, who is of the Oneida and Mohawk ancestry, was raised on the Onondaga and Oneida nations prior to moving to Syracuse, New York. And Dr. Thompson has an active practice as a board certified OBGYN, as well as a faculty member at Upstate Medical University, teaching and mentoring medical students and residents. He also serves on a New York State Maternal Mortality Review Board. And Dr. Thompson is a strong advocate nationally for Native American healthcare. And he is active in the care of Native Americans and underserved populations, as well as the recruitment and mentoring of Native American and underrepresented students into medical careers. And we have Dr. Megan O'Connell, who we just heard of. So thanks for also engaging in the conversation. Dr. O'Connell is the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board and a citizen of the Cherokee Nation. She is a board certified family medicine physician and has provided maternity care to hundreds of women. And she currently sits on the South Dakota's MMRC. And as mentioned, Dr. Jill Jim will be moderating this session for us. So I'll hand it over to you, Dr. Jim. Thank you.
Hey, can you hear me, Lisa?
Yes, perfect.
Well, good morning. I have been at those on the call this morning. Thank you for attending the call. And I want to just talk about the session here. This session will run from, I think we're a little bit over time, 1:45 to 2:30. And as Alicia mentioned earlier, we'll have 10 to 15 minutes for questions, and we'll head into break starting at 2:45. So I'm honored to stand before you today as we come together to discuss a critical issue affecting families, mothers, and communities in Indian country, which is maternal mortality. Alicia indicated I am Dr. Jill Jim, and I also have the privilege of working with this team at NIHB every day. And I also served as an MMRC member in the state of New Mexico as well previously, when I was a health director for the Navajo Nation. So as we all know, maternal mortality is a complex public health concern that significantly impacts our community's health and well-being. In Indian country, where maternal mortality rates are higher than the national average, we must take an action to address this issue and improve outcomes for our mothers and families. MMRCs conduct a review of maternal deaths that include American Indian and Alaska Native mothers. MMRCs are an essential tool in this effort by bringing together a diverse group of stakeholders. MMRCs provide a comprehensive approach to understanding the root causes of maternal mortality and developing solutions to address them, such as policy, system level, or practice changes. Through this discussion, we hope to better understand how we can work together to develop effective and sustainable review committees to help prevent maternal deaths in Indian country and advance our sovereign status. So, and just a reminder for those on the call, if you are not on mute, we do hear a hot mic. Thank you. We are excited to hear from you all and learn more about your experiences. Dr. Gamble, Dr. O'Connell, and Dr. Gamble, I'm giving you a new title, Ms. Gamble and Dr. Thompson on this important topic today. So I think, Alicia, you did the bios already, and maybe you can just briefly say your name and Dr. O'Connell so that people just know who you are.
Sure. Hello again, everyone. My name is Dr. Megan O'Connell, and I'm the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board that serves the tribes in North Dakota, South Dakota, Nebraska, and Iowa.
Dr. Thompson?
Can you hear me okay?
Yes.
Oh, perfect. Skoliscano, my name is Brian Thompson. I'm a citizen of the Oneida Nation, Wolf Clan. I'm up here in Syracuse, New York. I'm in labor and delivery today, actually. So hopefully no one will deliver in the next 45 minutes. But just to give you my background so you understand, I work essentially every day in a regional high-risk referral labor and delivery center, 25 beds with a 55 to 60 baby neonatal intensive care unit, 1 floor above us. So those are the kind of patients that we see and the problems that we encounter. I'm also on the National Board for March of Dimes, which is active in terms of maternal mortality and babies.
Wow, that's good to hear. And then Ms. Gamble?
Yes, thank you. Thank you for that promotion there momentarily. I'm Cindy Gamble. I'm Tlingit. I live and work in Washington State right now, but I'm so happy to tell you that I am talking to you from my homelands in Southeast Alaska today. So big smile on my face. And this is where my work started. You know, I made a decision that I really wanted my career to be at the front lines in the communities. And I started out as a health educator, talked to the elders, the health boards, saw what the needs were, started teaching childbirth education and family life classes in the schools. And it made me feel really good that these were requests from the community that they saw that they needed. And now I work in Washington State on behalf of the American Indian Health Commission and sit on the maternal mortality review panel there on behalf of the commission. And so that's why I'm here today and really happy to be with all of you.
Well, thank you. So I'll start with some questions and I'll just kind of have individuals talk about your experience. And I know all our experiences are different and not each state has an MMRC and as well. So I think those that are in states that are not familiar with MMRCs and their function, I think this group will play a large role to educate and provide awareness on how our experiences have been in the state MMRC groups as well and committees. And so I know that CDC is tasked with this to work with states and tribal nations to improve MMRC just because of the critical public health concern that I talked about. So some of you might be familiar with MMRCs, and then there was some good questions earlier about what do we do? How does this turn into action? So I think as we have posed questions today, I think the group can kind of highlight how those what goes into action and what items have they seen where they've made recommendations from these MMRC committees. So to get us started, maybe we'll start with down the line. I see the panelists. I'll start with Cindy here. To get us started, please share your background and experience working in maternal health, including your experience with MMRCs and what motivated you to serve on MMRCs. So we'll give you a couple of minutes and then we'll give some time to the other panelists as well. If you need me to repeat the question, I can do that as well.
Okay, thank you very much, Dr. Jim. I think that, you know, I am a woman, I'm a Native woman, and as growing up in our community, in our village, and then going off to school, I always wondered, why aren't our women and children valued more? So as I said, I was really happy to come back to Prince of Wales Island after school, after I was done with college, and be able to work at the community level and start working on some of these issues that were important for them. And it made me feel good that things like childbirth education and family life and parenting classes were important to them. When I became a tribal health director, I moved to Washington State and was asked to join the American Indian Health Commission to work on their maternal infant health work, as my bio said. And I also was asked to join the Maternal Mortality Review Panel on behalf of the commission. And it's just, I feel that being on the Maternal Mortality Review Panel, it's important work. And because I have wondered, why aren't our women and children valued more? Being on the Maternal Mortality Review Panel, as we call it in Washington State, I really feel is an opportunity to change the narrative to talking about the disparities, to saying, okay, we do value our women and our children, and what can we do? What are the recommendations we can make? How can we make their experience of birth, pregnancy, birth, and their postpartum and parenting time, how can we support that and make it better? And so it's just really important work for me. And to me, it's heart work. And I just love working with the partners and the other members of our panel and others as we're broadening out and looking, how can we really impact our disparities around this in Indian country. So really happy to be here today and appreciate the invitation. Thank you.
Thank you, Cindy. And then back to Dr. Thompson, do you want to go ahead and share your background and experience working with maternal health, anything that you might have left out in your introduction, and your experience with MMRCs and what motivated you to serve on MMRCs and MMRC?
Sure. I think the biggest reason is for me is that as growing up at Onondaga, just outside of Syracuse, growing up in Oneida here in New York, my dad being from Akwesasne. These are my people, these are my family. My wife is Danae. Family lives on Whitecomb in Arizona. And I see the disparities, but most importantly, and I think anyone who's Native can appreciate this, is that we see the invisibility of what's going on. The question is how you make others understand that and make us visible. The cultural competency, the culture that you bring to the committee is so important. And then the lack of I'm a physician, a Native physician. First, I'm Native. Second, I'm a physician. But how many Native physicians are on MMRCs across the country? How many Native physicians are a part of the CDC working on maternal mortality? So when this is all about advocacy. It's about caring for our women. Where I'm from, it's a matriarchal society. Everything comes through the woman. Our clan mothers are our leaders. They choose our chiefs. It's a traditional community where I'm from. So these things all blend in, and that teaching of trying to teach the New York State Maternal Mortality Review Board of the importance of this. So making the invisible visible.
Yeah, thank you for that comment. And then Dr. O'Connell, do you want to go ahead and share your experience?
Sure. Again, thank you all for joining us today. So I too am a native physician, so I imagine there's at least two of us on MMRCs, but we might be the only ones. So I appreciate that comment. I'm a family doctor, though I'm not an obstetrician, but I did a lot of OB care, both prenatal and delivery care, and that was something I was quite passionate about in my clinical practice. But I think, as the others have said, I've always been aware of the many health disparities faced by our communities, but particularly aware of those facing women and the dangers of pregnancy and childbirth, unfortunately, that they face. And so I now work in public health and work on trying to address the larger environmental factors that are causing and contributing to these disparities and these terrible outcomes, and have been privileged to join the MMRC in one of our states in South Dakota to help review the cases, give perspective on what's going on, and hopefully gain information that we can take back to the tribes that we serve, back to the clinics and clinicians that serve them, to figure out ways that we can prevent these deaths. As was mentioned in the previous session, you know, most of these deaths are usually deemed preventable, and that's really where our focus needs to be, on what we need to do to try to prevent any more maternal deaths.
Well, thank you for answering the first part of my question. The second part, I think, Dr. O'Connell, you kind of alluded to this, is that why don't you kind of give our listeners an example of why it's important for you as an American Indian physician to be on an MMRC? What perspective do you bring in some of these cases? Because when you are on these MMRC committees, they're not all American Indian maternal deaths, or you might be reviewing cases of other racial groups and as well. So I'm just wondering, in your experience, what do you feel like is important, because you're there, and maybe talk about what you brought, maybe in reviewing an American Indian case for a mother.
Yeah, thank you for that, Jill. Well, we're lucky in our state. I'm not the only Native person on the committee. We do have two Native people, so I will say I'm not the only Native voice. But I do think having at least one is important to provide context into the community and what might be going on in that person's lives. And it can be things that are quite kind of technical or practical, like what is IHS, right? Some people don't have any idea about that kind of basics about how the Indian healthcare system works, or what it might look like to have to travel for 2 or 3 hours to reach a delivering facility, and people may not realize where these communities are and how difficult it is to access care. So I think there is kind of, from the professional side, a familiarity with that healthcare system and how it works that a lot of people don't have. From the community and cultural side, of course, then you can bring that experience also into your review of cases, provide context for what might be going on in that person's lives, or questions that might be brought up, or bring up questions that the committee doesn't, that may be relevant to that particular community and that particular culture.
Thank you, Dr. O'Connell. And then Dr. Thompson, do you want to go ahead and add to those comments to see what you've experienced and bring in your perspective to an MMRC based on our culture or historical context or sovereignty?
Yeah, I think it was the last one I was going to talk about. It's that nation to nation, government to government relationship that is so important. You know, when I look at a lot of the data, and I'll use New York as an example, since this is where I live. a lot of times for Native people, we're placed into an other category, and we're not other. We're not a population, we're a nation. We're not a tribe, we're a nation. And it's that understanding, that fundamental understanding that we're sovereign people. Where I'm from up here, we issue our own passports. We travel on our own passports. So it's that uniqueness of bringing that aspect, that sovereignty aspect, which also goes along with governance, which also goes along with that mutual cooperation. All of those things, are beyond being an OB, and is that unique perspective. But when you look at other races and other ethnicities, we talk about a lot about Black African American maternal mortality, but we forget about the high rates of Native mortality and Native morbidity for moms. And they really are so similar. The numbers are so similar. Sometimes a lot of the experiences are similar. The poverty is similar. The racism is similar. The bias is similar, that they really need to be. There's such an outlier when we talk about maternal morbidity and mortality, is really to start to elevate and make these issues visible for Native people.
Thank you, Dr. Thompson, for that. And then Ms. Gamble, do you have anything else to add or agree with from the responses so far?
Oh, of course, I agree totally with everything they said. And it's just critical to have American Indian, Alaska Native representation. When we go through the MRIA form that Danielle talked about and look at the question of preventability, you go, what are the facility issues that come up? What are the provider issues? What are issues with the community, with the family? And all of those are important. And if you do not know anything about our culture and the culture of that particular community, then the recommendations that you are going to make are not going to hit home in the way that they should. And as both doctors discussed, that there's so many still myths, misconceptions, misunderstandings, lack of data, lack of understanding of sovereignty. All of those issues are really critical and create such gaps in understanding of what recommendations are really going to work for our people. And so it's just critical. And now every year that I've been on, that percentage of preventability has grown. And so it just says more and more. It really talks about the importance of our representation of not only physicians, but mental health providers, social workers, community members. Somebody talked about the importance of stories, of telling the story that really helps us understand what's going on. So having community members, having elders on committees, all of these perspectives add so much dimension and understanding, because there still is such a lack of understanding about who American Indian, Alaska Native people are, because there's so many different tribes, so many different cultures. So we need to understand it all. Thank you.
Yeah, thank you for sharing all of those responses. And certainly it is important to understand our landscape. Our Indian healthcare delivery system is so unique in various ways and complex, and sometimes people need a little educating. I know we have some hands raised, but I think we're going to wait until 2:30. So if you could just, I don't know if Alicia, if you're keeping tabs on who's raising their hand. So I will wait until then. So some of the responses led to sort of the next item that I wanted to discuss with you guys. And in that way, in developing tribally focused MMRCs, and sometimes we might hear the term as tribally led MMRCs. And I think we heard that earlier in the presentation. And based on your experience, where should this begin? Is that the local or state level or national level? I mean, what challenges do you see and how can we overcome these challenges? So I'm just wanting to see what your perspectives are and where we should begin. And I know there was some efforts along piloting some projects, but if those projects are not in your areas, based on what was mentioned, I wanted to see what your thoughts are around a tribally focus or a tribally led MMRC, and where should we begin? So maybe I'll go ahead and start with Dr. O'Connell again, if you could go ahead and start this conversation.
Sure. So we have been thinking about this for a while, and some of the challenges we would face in implementing this in our area is access to the data to perform the reviews. So even knowing who passed away from a vital statistics report, say, I'm not even sure we would be able to get that information, let alone the detailed information you would need from a medical chart to do a thorough review. Even in South Dakota, where I sit on the committee, for reviews of American Indian cases, they often have less data to review because it's difficult even for the state committee to get data. And if given our experience in other areas, I think we would have an even harder challenge. And so I think this is all part of a larger problem in tribes being able to access data on their members, but it would play a very significant role in the case of MMRCs because you need to gather so much and it's so detailed in what you need to do a really good job.
Thank you for sharing that. And then Dr. Thompson, do you have any other perspectives like local, state, regional, or national, maybe, or some options?
Sure. I think it depends on what you're trying to in some way accomplish. When you're looking at maternal mortality itself and some of the reasons and the causes for it, each area is a little bit different. What occurs up here in New York is completely different. What occurs in Oklahoma or South Dakota or Arizona, New Mexico, Alaska. But there are some commonalities, and so I think when you're fortunately when you're looking at, and these are hard discussions to have, the numbers of moms who are Native who are passing away are relatively small to try to have a monthly or a bi-monthly meeting on a state level, and it may be better either on a regional level or even on a national level to really kind of make some understandings, because I think there's commonalities. And I encourage everybody, the report that was talked about, the 36 or 37 MMRC committees that talked about Native people, is to go in and look at the individual committee reports. You can pull them up online because it's really enlightening when you start to see what is going on in each individual area. But the first thing is what was said is a problem with data. It is extremely difficult, or not impossible at this point in time, to get accurate data. Number two is maybe to broaden it a little bit, and if you have a national or a regional Native maternal mortality, but also add in what's called morbidity or severe complications, conditions that occur during pregnancy. So I'll give you an example. So we look at numbers for mortality, and I'll try not to go in the weeds too much, and I'll stop. In terms of 100,000. So I think the number that was quoted today, because you can look up various numbers for Natives, we'll say 30 per 100,000. If there's only about 27,000 deliveries across the United States for Native people in a year, the numbers are going to be relatively small. But I'll take Arizona, for example, where severe maternal mortality, those near misses and severe things that occur during pregnancy, heart attack, stroke, being on a ventilator, enlarged heart, getting a blood transfusion. For Arizona, it's about 300 per 10,000. And that's affecting our Native women, that's affecting their families. And maybe to broaden it a little bit and look at both, because if you can stop sometimes the severe complications and learn a little bit from it and take it into some of our local areas, you might be able to prevent and bring down that number of preventable causes from 93% for Native people down to a much, much lower number.
Before Cindy goes, can I just jump off of that and add something? I agree also the number of cases to review could be a problem because it's the absolute numbers are quite small. So in addition to what Dr. Thompson said, I think a possibility would be also to review those cases that had excellent outcomes. So this is a review of births. You for sure review all the ones with bad outcomes, like that resulted in a maternal death. It's possible in smaller areas, you could even review all of the ones that had a complication, but that the mother did not die, a serious complication, like Dr. Thompson has saying. And again, depending on the area, you may be able to review all of the births depending on how small of an area, but even at a state or regional level, you could take a sampling of those and also review those cases that had good outcomes and look for what went right in those cases that didn't result in something bad happening. So you have almost like a comparison group. So you're not just saying all these negative things happen and we need to prevent them. You have this other group where you can say, all these things went right. Why did all these things go right? And we had a good outcome.
Thank you for sharing that. And then Ms. Gamble, do you want to go ahead and add to the group?
Sure. Yes, I agree with everything. That the challenges are definitely data and our small populations in different areas. So then how would they be put together? Being on the maternal mortality for review program for a panel for Washington State for I don't know how long. I have always wondered why we just look at the pregnancy related and not the pregnancy associated deaths too. And then as we started our project, the American Indian Health Commission, and we really started thinking about how to approach this, we are in alignment in our thinking in that when we look at this, it's not just looking, we have to be true to our traditions too, right? We can't just go with what the latest and greatest is happening and nationally. If we want to be true to our culture and our traditions, we look at things holistically. And so again, that approach of looking at the whole person, not just what did they die of and what is causing their illness, but I totally agree with both of you doctors, you good doctors, that the health is also very important. And so our approach in a project we're doing in Washington State is we are looking at the health of pregnant birthing, Native pregnant birthing and postpartum people, and going into communities and talking about these issues, because we have to look at the whole person. And just focusing on death may not resonate with certain tribes and cultures and traditions. And so we do want to look at, I totally agree with you, Dr. Thompson, about the morbidity. We think that's really important too, because it does, there's a continuum there, right? But again, as with Dr. O'Connell, yes, the health is very important. We want to look at what keeps us healthy, what is working, and look at the whole person, the whole picture, and not just that little piece, that siloed piece of death. And I think that is being true to our traditions, and how we do look at people, and we do look at health and healthy people. So I think how we do it to maintain confidentiality and efficiency will be a wonderful challenge, and it may start small, but as an Indian country does, it grows. We see what works for tribes, and then other tribes want to jump on. So I think we start, but it will be a good problem issue to look at, how we can do this in a good way, in our way, and with all of this wonderful expertise and resources we have.
Well, thank you for all those comments. And as I was asking this question, I was also thinking about, and we probably all know the answer to this, is that a lack of funding, right, to do this. And there would have to be a lot of multiple jurisdictional agreements for this to happen too. I mean, if the PRAMS data was just looking at data that was already accessible, now you're looking at an individual's environment beyond just visiting or beyond transmitting a record from the hospital to the state. And so I think that there's a lot that we can do and learn from, but we also know that we need funding, and that's definitely something I think will have to be sort of at the top of our list all the time to address maternal mortality. So I don't know if I know we have about 9 minutes left, and I wanted to just kind of share some of your opinions. I saw a question earlier, or I heard a question earlier about policy changes and how this can be actionable. And I wanted to ask each of you about what recommendations do you have at addressing maternal mortality to the extent that they're there locally. I know we have a vast number of either public health or medical professionals on this call. There could be state representatives on this call. And so for us on the call today, how do we take action in addressing maternal morbidity and mortality among American Indian women in our own communities? And even though we're not associated with, not all of us might be associated with an MMRC, but what can we do in the work that we do on an everyday basis? So maybe I'll start with Dr. Thompson.
Can you just repeat that again? I'm sorry, I was getting a call from outside the room here.
It's really a closing comment on what recommendations you have addressing maternal mortality and morbidity locally. And so just letting people know, I mean, we have a vast audience here today, and just to encourage everyone, these are some stuff you can consider.
Yeah, I mean, I think I agree with everything that's said. This is such a difficult discussion because we're about life and everything is alive, and we're not, we're focusing on death here, but or bad outcomes. I think first and foremost, I think every health department, every state health department, and everyone that is dealing with this should have Native involvement. It's so vitally important because it makes a huge difference on a daily basis. But also too, just the teaching, and I'll leave you with this because I think this is more important for me than anything else. We were taught 3 different things: skana, peace, peace within ourselves, and peace with how we work with other people. Ganigolio, using a good mind. And I think we were talking about that today. How do we all work together to use a good mind to have the best outcomes for our people? And Gasastasra, the strength of coming together as one with that one mind and that good mind and that good voice. And I think, looking at patients, exactly what you were saying, looking at patients as a whole, understanding where they live. I can't take I can't take my insulin when I'm pregnant because I don't have electricity, and I don't even have a refrigerator to even keep it in, if I even was able to get it. And I don't have a car to go get my insulin. All these different things. One of the things that hurts me, and I keep bringing up Arizona because my wife is from there, but they have some wonderful stats, and Washington State has some amazing stats that severe, if you live on a nation in Arizona, and I'm just going to quote the number for you here. It's from their MMRC. If you live in Arizona and you live on a nation, and you have no care, your rate of having a severe outcome is 1,123 per 10,000. That means you're going to have a severe outcome with your pregnancy 11% of the time. If you live off a reservation, off a nation, it's 420. It shouldn't be that living on our own land, where we would all want to be, should be a detriment to our health. I'll give you another stat. Having high blood pressure, 7.3% of people have severe outcomes if you're native in Arizona. And if you're not, it's 2.4%, you'll have a severe outcome. The reason I'm saying all of this is that, you know, I think there's this invisibility of this crisis that's occurring within our community. I've seen moms die during childbirth. It is the most gut-wrenching, no one ever goes through. But bringing that passion, bringing that understanding, holistic approach is so vitally important for whatever comes of a MMRC or a native health review.
Thank you, Dr. Thompson. I know there are very large differences, and I think we all resonate with that today. So I'll go to Ms. Gamble. Do you want to say some last minute words on how we can take a role of taking action in our communities?
Well, I just want to share what we're doing in Washington State with our partnership with the Department of Health there. When the 2019 Maternal Mortality Review Panel report was released, it showed that American Indian Alaska Natives had the highest disparity of any other race or ethnicity in our state. And so we were able to get some funding for a project that we call Conversations about the Health of Native, Pregnant, Birthing, and Postpartum People. And in the first phase, it had to be virtual due to COVID, but now we are in phase 2 and we're starting to do on-site conversations. And we just think that this is really important because just going into the community and talking to them about this is seed planting, right? You're bringing attention to it by visiting them and telling the community, we think this is important. What do you think? And we find that they do think this is important and they have lots of ideas and wisdom. And so I think we just have to start. I know when I said that about the wonderful resources, well, you can tell by looking at me that I've been around for a long time. And when I started my career, we didn't have a lot of doctors, native doctors in it. So it just fills my heart to see all of you, both of you, and hear your wonderful wisdom. So I see this as resources. We are getting more of our own people, even though the gap is still huge. We do have more resources than we did in the past, and we do need a lot more resources. And we talk all the time about the need for equitable funding versus equal funding, that the groups that have the highest disparities should have funding and resources to match that need. And so there is a big gap. But I think that we just have to start somewhere. We have to find advocates who are interested in this, go into the community, talk to the elders, get the elders' input, get their ideas, and be intentional about keeping the focus on the importance and the need of the health of our pregnant, birthing, and postpartum people. It is foundational. It is our tradition. It is our future. And we just have to start. You know, there's so many things going on that all of the maternal infant health sometimes gets pushed off the table of priorities, right? And so we just need to be there and keep the focus on it, because I do see change, and I do see positive change in our state. And I'm very grateful for the partners and allies that we have. And so I know it can be done, and it does take relationships. It takes us advocating for ourselves, and it takes our allies and partners also holding us up and supporting and understanding all the needs. And the needs are going to take a lot more time to take. It's been 500 plus years of racism and trauma and attempted genocide. It is going to take time to heal those wounds, and we need to bring our traditions, our medicine people, our elders, our ways into this, and we just have to start and just continue. Thank you very much.
Thank you for that. And then Dr. O'Connell, I'll leave you with the last couple of words.
Thank you. And I know we want to take questions, so I'll try to be quick. I agree everything that's been said before, and I'll just try to add some recommendations that maybe you can do now. The first thing I would suggest is, look, if you're interested in this topic, look into the MMRC committee in your state or in your area and volunteer. I was actually on this committee before when I wasn't in this role, because they needed doctors to be on it. And you don't always have to be a physician or a healthcare worker. But there are often committees like this, which I'm sure we're on a lot of them, but if it's something passionate you're about, they probably need your voice. So reach out and join that committee, even if it's at the state level or the regional level. There's usually not enough people to go around for all the committees. So go see, there might be an open seat, or you can watch it and there might be one coming up. And then in terms of prevention, I think there's, as was mentioned, clinicians and public health people on this call. I think there's a lot we know already works to have healthier moms and babies, right? MMRCs are very important to collect more information and monitor what's going on. But we also know a lot about health disparities and the kind of supports that moms and families and young children need to be healthy, in terms of, stable housing, healthy food, all of those good things, right? Safe places to live, transportation was mentioned. And those are things I think we work on all the time. But if you keep that in mind in terms of what are the things we know works that we may be able to influence right now, those are probably the things that will have the biggest impact in the long run on maternal mortality. When you look at the recommendations that often come out on these committees, they talk about things like hemorrhages or emboli, which are all important things to try to avoid. But in my experience reviewing, it's everything that's happening outside of the delivery room that's really having the greatest impact. And so if you work in public health or you work with your communities, you can support maternal child health and better outcomes in whatever you're doing by supporting families, supporting healthier living situations, supporting healthier communities generally, because those external factors are having a major impact on the health of moms and babies. And I think we can all do that. And I think we probably all do that in our work, but being more conscious of it, and maybe really thinking about how you can support families and pregnant moms can go a long, long way to help address this issue.
Thank you, Dr. O'Connell. I am going to see if there's going to be any raised hands. I know there's some questions in chat, and our CDC partners have been answering those kindly. Alicia, do you want to go ahead and navigate the questions?
Yeah.
Some have answered and some haven't, so I'll go on mute.
Yeah, so I was well, first off, let me express my sincere gratitude to our panelists, and thank you, Dr. Jim, Cindy, Dr. O'Connell, and Dr. Thompson for sharing your knowledge and expertise with us. So I have been watching the chat, and I'll give it to Fabricia Lateral. If you want to unmute yourselves, I know I saw your hand raised earlier, and then we'll move on to Shay after. Thank you.
Hi, can you guys hear me? So first of all, it's an honor to be here, and I'm very glad to have the chance to hear doctors and Cindy being seeing each other in those conversations before in various places. So it's nice to be here. I just wanted to and kind of like share 2 things that have changed in South Dakota as a result of like having Megan and talking to her and listening to her in the conversations that we have here in South Dakota. I'm right now working on a combined report of maternal and infant deaths, because with the work of the Child Death Review and the Maternal Mortality Review Committee, we realized that many of the risk factors and the recommendations overlap. And because we are a small state in South Dakota, we want to prioritize those so that we can impact those, because the root of the problems are the same. But one thing that has changed in our analysis in South Dakota, because of like understanding better what it means to be an American Native, is that we completely changed the way we classify race in our analysis. Like when we are doing this analysis right now, and we are looking into Native people, we are doing everything that we can to not undercount the cases. So if a person, for instance, is recorded as being Native American and something else, we are counting that person as Native American because we are acknowledging that person's citizenship. And there are other things that we are looking into. We have the possibility here in South Dakota to separate tribal land from non-tribal land, and to separate rural areas from non-rural areas. There is an overlap in South Dakota with living in tribal land and living in rural areas, and we want to take those things into consideration when we look into our disparities. But it only changed because we have Megan and other natives in our committee talking to us all the time and visiting the Department of Health all the time and making a point. And so I just wanted to share that. And I also wanted to share that one of the aspects to take into consideration when we are looking into the barriers to do more with the investigation of cases is the legal limitations. It is very hard to have access to information when you don't have something in your state that makes access to that information mandatory, because there's no legislation in that. So that's the other aspect that we would have to work if we want to pursue a tribal focused MMRC is working on, like, because like Megan has the public health authority and she has a crazy hard time having access to information, and she already has the authority. So working through those things to obtain the authority to do those things is another thing that I think we would have to work in the country in order for us to have better access to information. So I just wanted to share those things, that experience that we have here in South Dakota and how that has made already a difference. It doesn't look like much, but it is making a difference for us.
Thank you for sharing your experiences. I don't know if the panelists want to add to that, but it sounds like you guys are doing a good job adding and recognizing the increasing of the samples. I don't know if you guys have any comments or feedback.
Just
I do
keep
know
up
that
the good work. I think it's wonderful. That's very smart, what the decisions you're making. You have Dr. O'Connell as a great resource. So just keep up the good work. You just have to start and keep going.
Thank you, Cindy, and thank you, Fabricia. So I'll hand it over to Shay. Oh, Shay, can you unmute yourself if you have a question? If not, I'll pass it over to Alicia. She did put in the Q&A. One of her question is, oh, go ahead, Shay.
Hey, sorry, I was having a little technical difficulty here.
It's okay.
For some reason, my video won't work. So my name is Shay. I'm a midwife, originally from upstate New York, but I'm working with South Central Foundation in Wasilla, Alaska, in the tribal health system right now. My question is slightly off topic. I'm not sure if any of you can speak to it, but it kind of relates back to one of the slides that was shown in the first presentation, where it showed the number of maternal deaths per 100,000. And we saw how, American Indian, Alaska Native was elevated. But I also noticed in the first column that Native Hawaiian and Pacific Islander was like dramatically elevated, almost double, American Indian, Alaska Native. And I was wondering if there's anyone who could speak to why that might be, if there's anyone looking into, what is driving the extremely high rates of, in Native Hawaiian and Pacific Islanders, and if there's just anyone who has experience with that, or anyone who can speak to, if there's anything being done to address that.
Hi, this is Ashley. I'm the senior epidemiologist on the maternal mortality prevention team. So we can jump in, but I don't know if you want anybody from the audience to talk about that first, or if you want to hear from us. Okay, I'll jump in and then somebody from the audience can share. So our PMSS data did show that was the first time that data was disaggregated. So we were excited to be able to have that data. And I think everyone was maybe a little bit surprised at the magnitude of the disparities. So being the first time we have the data available, we unfortunately don't have a lot we can do. The numbers are small, but we are working on what else we can learn. The Hawaii, and then we're funded Guam as a partner in Erase MM, and they have MMRCs, which that's really going to be, as Danielle mentioned in her presentation, that's the richness of the MMRCs, as they can really dive deeper, get the local context. So we're looking forward to hearing more from our partners in those states about what they're finding with their recommendations for prevention. I think we're also looking at funding. I think we are also funding other partners in the Pacific to help us to understand more. We have some fellows coming on board. We're working with PHOA to help those island jurisdictions learn more about maternal mortality and stand-up committees in their areas. And Tegan, if you're still on, I want to jump in if I missed anything, but it is something we're looking at. Unfortunately, we don't have a lot of data right now to share, but we are working on it.
Thanks, Ashley. I just wanted to offer that the PMSS data that was shown is also primarily showing the Native Hawaiian, other Pacific Islander population that is showing up specifically in continental US, Hawaii, and Alaska data, as PMSS doesn't fully cover all of the territories and freely associated states. So a nuance of this is also, you know, we are aware of some state-based Title V MCH programs or MMRCs that also are seeing this disparity and at least making recommendations for this population. So I just wanted to flag that for this group's consideration and awareness too, that this may be then driven by those state-specific contexts and data to action frameworks.
Thanks, Tegan. And I think also Dr. Thompson mentioned the state reports that are available online. We can drop a link in the chat to review to action, and you can look at some of those states. And I see Utah and Washington State also chiming in for what they know at their state level.
Awesome, thank you.
Thank you. So we have about a few more minutes and I'll maybe go on a couple more questions. So I have Alicia dropped in a chat. Why is it difficult for tribal nations to access data on maternal morbidity, mortality of Native people? And is there a lack of infrastructure to allow the transfer of this data? Or are there legal issues preventing the sharing of this information? I know you guys kind of touched on the data access barriers. So, and if you want to chime in more on that, Alicia, but I'll give it to the panelists.
I mean, I'll dive right in there. God, this is something I work on a lot. So the why, I think I can't answer, but I can answer the other parts, is that neither of those are the problem. While technology could potentially be better or worse, it's not generally a barrier to data transfers, especially if you're talking about something like a list of names of Native women who died in a particular year, right? That's not a huge data transfer, and it can be done securely in a variety of fairly low-tech ways. And in terms of the legal issues, as Fa alluded to in her comments, at the federal level, tribes should be able to receive this data from the states or from whoever's filling out the the death certificate, honestly, like a clinic or like the Indian Health Service, if it happened in the hospital, for example, but they just aren't given that information. So the technology and legal are actually not barriers, but it has been our experience, and I think many others across the country, that receiving this information along with much other data is very, very difficult.
And I'll just chime in that data sovereignty is a very big and sensitive issue in Indian country right now. And there's many pieces of the bidirectionality of it. So I know in Washington State, we are now currently working on American Indian and Alaska Native data ownership and material sharing agreement, so that it is going to be very clear and spelled out about who owns the data and how the data is shared. And so it's a big issue and complex, but I'm glad that we're working on it.
And we'll have maybe just one panelist answer this last question before we head into break. Is from Shelley Means. Is there any spiritual, emotional, mental health practices to support you and the others who serve on the MMRPs?
I mean, I can only speak, for myself. When we're conducting our New York State MMRC, we try to support each other. We do tell the stories of each individual person. I think that was mentioned today. But as a Native person, when you leave, because of all that, of what is discussed during that day, I mean, we review, we have 90 maternal deaths a year in New York State, so we're reviewing an awful lot of them. It's just heartbreaking at the end of the day. But to come home and and each place is different, but in where I'm from is to cleanse myself, is to clean myself, through ceremony, through song, through dance. If you never want to lose any of that, and then you lose your identity of who you are. So, but I do, try to help other people that are on the committee to the best that I can. But it's so important to cleanse yourself. In our area, we would say that we take the softest cloth and we wipe our eyes so that our vision is clear, and we have the clearest water to drink to clear up that pain and that grief when you hear these stories that are in your throat, and to be able to wash out your ears of what you hear. But we do all those type of things because what was mentioned before, we're all about life. Everything around us is alive. The air is alive. The ground is alive. The animals are alive. We're a part of all of them. They're not innate objects. We're a part of a larger group, and we're just a portion of that. So I try to bring that into the committee, but more importantly, when I leave, is to try to wash some of that away, to go on for another day.
Thank you so much, Dr. Thompson. What a great way to end today's discussion. So again, thank you to our speakers for joining us on this critical discussion on MMRCs and its relationship with maternal health promotion and for our Native Nation